everyone. Excuse me. Thank you. No, that's okay, thank you. Hello. So we're just running slightly over time, but it's okay. We can make back up the time. So next to speak, we have Dr. Edward Johnston. He's a consultant in oncological interventional radiology here at the Royal Marsden Hospital. He has both an NHS and private practice at the Royal Marsden, and he is also the Chelsea Institute of Cancer Research Biomedical Research Centre, working there too.
Right.
Sorry, Ed.
Carry on.
I was just going to give a brief bio in terms of he qualified in 2009 and got his PhD from UCL in magnetic resonance imaging in 2017 and completed his training in interventional radiology in 2020. He has a lot of clinical interests, and his particular interest is in biopsies and tumour ablation procedures. He's investigating new, minimally invasive techniques to improve the understanding and diagnosis of treatment of cancer. So I know originally we were due to have Nicos Fatiadis join us. However, unfortunately, he couldn't join us today. But I'm sure Ed will just be able to talk to this as well too. And so without further ado, I'd like to introduce Dr. Johnston to speak. Thank you.
Thank you. Thank you very much. It's a real pleasure actually to speak to so many patients. It really it's quite unusual for us. So it's really loving the opportunity of being able to sort of get what I'm doing out there, particularly because not that many people know what an interventional radiologist is. So I'm going to try and keep it to leiomyosarcoma, or leiomyosarcomas, as I should probably say. So Nicos, this is Nicos here. Sorry he can't be here. I think this is his house. I haven't actually asked him. He gave me some presentations that he's done before, and this features in every single one. It's a shame it's not my house. It looks lovely. And I think he is actually coming back from Greece at the moment. Sorry, next slide. I'm just getting to grips with which way it's going. There we are. Okay, what is interventional radiology? So it's pinhole surgery, so even less invasive than keyhole surgery. We are radiologists, so we have image guidance. It's very high tech. Lots of new procedures, we're able to help with diagnosis from the biopsy standpoint, and also treatment, ablation, which I'll talk about. There's a couple of papers, stating that even though lots of you, probably most of you, will have had a biopsy, not a lot of people know what an interventional radiologist does, but the sort of broad concept is that we try and spare patients very invasive open surgery where possible. So the tendency towards, for example, cardiac stenting was actually invented by interventional radiologists to sort of replace open heart surgery where appropriate. It doesn't completely replace surgery. Sorry, Nicos's house again. Okay, going to hold it that way. So interventional radiology at the Marsden. So we mainly do biopsy ablation procedures, but we also drain abscesses, en bloc stents. We have a huge multidisciplinary team, radiographers, nurses, lots of kit, very busy rooms. We don't have much space, particularly here in Chelsea where estates are premium. The cases are going up and up and up. We've been really fortunate to have Dame Deborah James really get our name out there, particularly in the Royal Marsden, because actually she was very open about a lot of our procedures, really kept her alive, her words. This actually resulted in the royal visit. That's Prince William. We're showing our our robot, which we're pioneering at the Marsden. Why did I do IR? Well, this sort of thing just confuses me. I feel it just doesn't stick. I'll look at it, I think I'll understand it, I'll remember it for a few minutes, and I'll go back and I would have forgotten again. I'm a simple man, but maybe there's something to this. This is this was some BBC coverage about this incredible piece of work by Charles Swanton, who's a real pioneer. He's one of these clever medical oncologists, basically saying that cancer is infinitely complex, which means perhaps maybe we can never fully understand it. Due to its real diversity, Cancer Research UK have said about this that early detection of cancer was vitally important. A tumour starts as a single uncorrupted cell, but then becomes and mutates millions of cells that all behave in different ways. And here's Charlie saying that I don't want to sound too depressing about this, but given the infinite possibilities, we're actually going to have to try and focus on earlier stage treatments rather than come up with cures. So what do we need then? So we need some form of surveillance program in terms of imaging, so we can actually make sure that we can detect any relapses early. We have various tools at our hands. We have X-ray, we have ultrasound, we have MRI, and we have CT. But we also have more complex sort of second generation, as some people call them, imaging techniques of functional MRI and CT. These can all be deployed as part of surveillance programs, and the ESMO guidelines in 2018 basically separates high-risk patients based on grade, size and site from low-risk patients, and you need a slightly more intensive surveillance strategy for the higher risk patients, so we can intervene earlier. So some thoughts on surveillance. So why do we do surveillance? Well, surveillance is there to guide treatment. Early cancer is easier to treat, and for surveillance to be effective, we need excellent treatments. Now, radical approaches may be unnecessarily morbid, and preservation of tissues is important, especially in the context of metastatic disease. You can have more tumours crop up. So liver resection. So let's think about this then. We've got what to me look like two very different situations. You've got this on the left here, a 13-year-old with undifferentiated sarcoma in the liver, large metastasis, and then you have this very small metastasis just posterior to this. This is the right hepatic vein here. Now, if we're in a hepatobiliary MDT, I don't want to speak for the liver surgeons, but the operation here, the surgery, is identical. So you actually have to think, what is the complication rate? And these are two different situations. If I was this 13-year-old daughter's parents, I would be pleading that the surgeons would proceed with the right hepatectomy as quickly as possible. If I was this patient, I would be pleading that they don't. We find a tumour. What do? We go to multidisciplinary sarcoma team. This is really important. This is where we all get together and very politely discuss all of the different treatment options that are available to us. Medical oncology, surgical oncology, radiation oncology, and now interventional oncology. So we have a bit of a debate and decide what treatment is best deployed in which situation. This is more or less the only sort of one of these Kaplan-Meier graphs I'll show you. This was the Sabre Comet study. This was about stereotactic radiotherapy. They randomised patients to receiving very aggressive radiotherapy of 1 to 5 metastases. We call those oligometastases. in combination with best medical therapy versus best medical therapy alone, no sabre. And what this showed is basically by the end of the study, more patients who had the sabre were alive. So patients who have their metastases treated do better. What about sarcoma? Well, this is a paper from the French sarcoma group. You know, it's not a prospective randomised trial. There are, of course, difficulties in doing that, so it's a bit of a murky study. But 281 patients, retrospective analysis, similar sort of design, but sort of looking back rather than a prospective trial. Most underwent ablation, but a not dissimilar proportion didn't. The groups were similar in terms of their sort of characteristics, so they were comparable. But it was found that in the patients who had ablation, survival was better, and that persisted even for multiple treatments. So, what can we offer as interventional radiologists? Well, we can offer biopsy to sample the tumour. I decided to kind of focus on ablation today, just because you probably know a little bit more about biopsy. So, what is ablation? That's killing small tumours with energy imparted from needles. And what we're trying to do is cure. We're going for cure in that situation. We can also offer embolization, which in leiomyosarcomas may be a bit more niche, but we can do it. This is where we block the blood supply. Usually, this is a palliative treatment. We're not aiming for cure. We're looking to devascularise. I've just gone back, haven't I? Sorry. Right. So what about ablation then? So ablation actually came. The history is a bit complicated, but there was this interesting story about one of the pioneers in ablation. Basically was doing a biopsy of a parathyroid adenoma, and basically the endocrinologist came back and said, "What did you do to that patient? Their calcium's now completely normal." And he thought, "Oh right, well he had just done a biopsy, so this sort of he thought created some bleeding and caused the adenoma to be treated." And basically then the modern ablation was born. So that same guy, Gigi Sorbiati, actually a collaborator of mine, is the pioneer in radiofrequency ablation. So he's still alive, he's still active, he's still going. This is a young specialty. Microwave ablation, slightly higher power. Cryoablation, so radiofrequency and microwave both heat tumours. Cryoablation freezes it. And then we have nanoknife, again slightly more niche indications, but we can electrocute them too. So these are the options then. So we have the electromagnetic spectrum. You can see radio waves are here. That's radiofrequency ablation. Then if you have a higher frequency up the electromagnetic spectrum, that's where microwaves are. And those, much like a microwave oven, basically cause your, if you put a piece of chicken in, it's not the best way to do chicken, is it? But but it does shrivel and it doesn't come back. Whereas if you freeze a tumour, like put some chicken in the freezer and then unfreeze it, it looks like it did when you put it in. It preserves collagen. That's the difference with cryoablation. And what cryoablation does, very, very cold temperatures, you're giving the tumour internal frostbite. So what does this all mean? Well, cells cannot survive very low or high temperatures. So I can forget all of that. I just have to concentrate on covering the tumour, whether they're really, really bad cells or slightly naughty cells, or it doesn't matter. What we're looking for is an adequate ablation zone. So what does radiofrequency do? Well, you basically have a source at the tip of the probe. So this is a needle that you physically put into a patient, and that basically has an electrical circuit that the patient actually becomes an electrical circuit, and there are some ground pads on the thighs, And what that does, it causes ionic agitation, frictional heating, and then the proteins of the cells denature, again, no matter how they're behaving. The radiofrequency can have slightly different ends, which can increase the size of your ablation zone and also make the needle more stable in the tissues. What about microwave? Well, this is a little bit like radiofrequency, but higher energy. It causes these oscillation of water molecules called dielectric hysteresis. Works in exactly the same way as your microwave oven, but it produces an ablation zone here. Okay. Now the concept is if you have a tumour, let's say in red, then you've got to completely overlap your tumour with your ablation zone. That's the way it works. It's very similar to surgical margins. Cryoablation works by basically argon gas flows in very high pressure through a central part of a needle and then decompresses. And what this causes, this is called the Joule-Thomson effect. This basically causes local temperatures to drop very rapidly. And basically because, like when you put ice into a freezer, it expands, that expansion causes a drop in density, and it means that you can see very clearly precisely where your 0 degree isotherm is. The -20 isotherm is about 5 millimeters in from this, which is why you need to, again, get a good margin. I'm obsessed with margins. And what happens, you do a couple of freeze-thaw cycles, and this causes osmotic fluid shift, and basically the cells, the cell membranes shatter, and then fluid comes into the cells, and then they die. So that's how cryo works. How do we decide between these different treatments? Well, radiofrequency has the most evidence because it was, it started in the 90s. It's very gentle, so the lung's very gentle, so we use it in the lung. Microwave, well, that's more powerful, that's faster, you get bigger ablation zones, can be a bit unpredictable, very good in the liver. Cryoablation, as I showed you, you can see the ablation zone very well. It can produce huge ablation zones. You can ablate massive tumours with cryo. 20 needles, but you can also reposition those 20 needles. Early experience had high complications. There's complex history surrounding that, but bottom line is it sort of has a bad reputation because of that. For example, in the liver, it's the most expensive. It's the slowest. Not many of my colleagues like doing it because you have to wait there for quite a long time and not do very much. But it's beautiful. I find it beautiful anyway, and it's best for soft tissue. What is the concept? So, as I alluded to earlier, you've got a tumour, and what you need to do is cover your target tumour, no matter what it is, with a safety margin of 5 millimetres in 3 dimensions, and also you want, of course, internal complete cell kill as well. So for larger tumours, that means multiple overlapping ablation zones. But that makes more complexity, so there's more room for error, so ideally you don't do that. So a lot of what I'm sort of about to say is basically derived from the other cancers. Whenever you look at charts like this, you think, where's sarcoma? Other. Could it be in there? Yes, a lot of what I'm about to say is extrapolated from the more common cancer types, particularly GI cancers. I've just shown you this one as well. You gave me a sort of a sigh of approval, so it sounds like you've looked at these as well, because here's another one, WHO, sarcoma's not on it. So what about the BCLC guidelines? So this is Barcelona Clinic for Liver Cancer. This is basically a real success story of ablation. Look, we're in the guidelines. Where are we in the guidelines? 2 centimetres. 3 centimetres. Why would that be? Size matters. The smaller the tumour, the higher the chance of complete treatment. Less chance of complication. An RF needle here, for example, they make these as big as 5 centimetres. If you have a 0.5 centimetre margin on either side with perfect needle placement, you can treat a 4 centimetre tumour. In liver ablation, you look for hepatocellular carcinoma, less than 3 centimetres, 90% treatment in the guidelines. 3 to 5 centimetres, then your local recurrence rate starts to go up. 5 centimetres, rarely attempted. The major complication rate, because we're dealing with 1, 2, sometimes 3 needles for the most part, is much, much lower than surgery, typically 5%. Typically one night stay. But desmoid cryoablation, this is a bit of a black sheep in the ablation family. That's because in this cryodesmo trial, tumours were typically 10 centimetres, so much bigger, overlapping ablation zones. Major complication rate, 22%, much higher. That's basically because of the size of the tumours. Larger tumours did worse. That was the only predictor of treatment success in that trial. Now cryodesmo 2 is being designed to see if we can treat earlier. Rate of growth is also not always linear. It can be unpredictable. You can be monitoring something and suddenly it takes off. So we should consider ablation as soon as we have an inkling that tumours are growing. Something about embolization briefly then. This is basically, you may know from uterine fibroids, so leiomyomas, that we can block the blood supply to tumours, and this uses small particles via a small sheath in the groin. So I just thought I'd go through some quick case examples. This is an ideal liver ablation. Small lesion, single needle, huge ablation zone, in basically somewhere in the liver where there's not very much real estate at all, and this again, you would probably have to have a very wide resection or maybe even a right hepatectomy for that lesion. Went home the next day. That's not going to come back. I can tell you now. I'm sure you can all appreciate that too. So, Leiomyosarcoma metastasis, yes, we can do larger tumours. This was a 6 centimetre tumour that we did with 3 needles and repositioning. But look, by a few months later, there was perhaps unsurprisingly a nodule on the edge of the ablation zone. We can go back, we can ablate it, and actually this did have a complete treatment. But it did recur, and with the size, any time you go back, size is such an important predictor. This is a case I did on Tuesday. Actually, it was a colorectal metastasis. First on the list, straight away, single lesion, robotic guidance, single placement, and 10 minutes, discharge straight away. The team, wow, Ed, you're amazing. No, I'm not. It's just that it was a small lesion. This was a leiomyosarcoma metastasis, just showing you the ablation zone on the tumour, and we're starting to do some image fusion. It's not as important in lung, but in liver it is much more important. This was the next case on the same day. So yes, you can see March 2023. Can you see it? Yeah, good. Have a job. September 2023 had really grown, and then 1 month later, oh no, this patient's now on the table. You can see the growth rate here. It's the only site of disease, so we want to treat it. And any cancellation of the procedure, and by the time you've arranged any other treatment, I think we've lost it. So what's the need here? Lots of overlapping ablation zones. Oh no, Ed, you're terrible. 1 hour, one and a half hour procedure, 3 night stay, ablation anteriorly, in the middle there, and posteriorly, big zone there, higher risk of complications. Given the option, I would have loved to have treated it back then. Not saying that we knew to do that then, but these are some of the issues we're going to have to sort. You look at the follow-up scans, and you can see the ablation zone involuting there. Here, another case, cryotherapy for a sarcoma metastasis. Actually, this was in the middle of the COVID pandemic, we had it here, and we really wanted to treat it then, and the cryo wasn't available, and then it became available on this day, and it was in such a precarious position. I wasn't sure that I could get coverage, but again, it was the only site of disease. If only we'd treated it back then, you know, it wouldn't have been so near to all of these critical structures. That's the airway there. Oh look, we look at the PET CT and there's a recurrent nodule there. It is bigger, 4-night stay, including one day stay on intensive care. Unfortunately, patient died from that nodule there growing. No disease elsewhere. Had we intervened there, he may still be alive. So, difficult decisions, difficult decision making. Cryotherapy this is a good example. So, can you see small lesions, big lesions? Small liposarcoma, in this case metastasis, was growing. Single cryoprobe, single night stay. 2 years later, no disease on the scan. You're going to have to take my word for it. There is on that slice no disease, but if you scroll through, I promise there's no disease. Large desmoid cryoablation, 18 cryoprobes, extremely expensive, very morbid, but carefully selected case. I don't think I was a favourite person in the world for a few weeks. I'm probably still not, but I'm kind of hoping that in time this is going to shrink down. In an ideal world, again, we would have seen this patient earlier. Actually, this patient had 2 lesions, a small one and a big one. The small one's completely gone now already, and was causing her a lot of bother too. Multiple needles there. This was quite a nice case because this isn't. The objective here is not to completely kill the tumour, it's to kill enough tumour to stop the symptoms being bothersome. Metastasis here right next to the intercostal nerve, impinging, giving terrible pain. They're quite near the spine actually, a few cryoprobes and also a thermocouple into the spine or near the spine to check the temperature and to make sure we're not freezing the spine. Patient was palliative but was really happy with the treatment. Pain significantly reduced. Embolization, I'm not going to dwell on this because we don't do it all that much, but we have done some cases. Not that much evidence out there, and there's none really. There it is. Beforehand, we do an angiogram, we put some beads in. They're not the most vascular tumours, they're not like hepatocellular carcinomas, but you can see that there is some necrosis there. So what are we doing here to try and improve biopsy and ablation? Well, I'm interested in computer-assisted interventional radiology, so we have stereotactic guidance now, can really help reduce the number of needle manipulations that we do. In the lung, this is really encouraging because needle manipulations equals hemorrhage, equals getting a bit lost, complications. Most patients only need a single needle placement to completely treat their tumour. We're now the world's largest centre for robotic ablation. I've been developing some ablation confirmation software using image fusion. And then CT hepatic angiography. At the moment, we're only allowed to do 2 scans, one at the beginning, one at the end. What if your ablation zone doesn't look good at the end? Then you're kind of scuppered because radiographers get very nervous about giving lots of contrast. So this allows us to significantly reduce our contrast dose and get amazing quality images. And we can tailor our ablation zones and be a bit more gentle until they're perfect. And then finally, PET guided biopsies is something which I see on the horizon. I'm trying to work on installing the robot in the PET scanner. Couple of political slides. Ablation isn't very available. This red thing means that ablation's not available at all. Green means that it's very available, more than 3 treatment areas, and blue's somewhere in the middle. Other thing to say is that ablation that you get in the Marsden, unfortunately, I think will be different to ablation that you get at other centres. I think we need to do more work on standardising our procedures. If you look at cardiac surgery, if you get a coronary artery bypass, it will probably be the same in Leicester as it will be in Exeter. I don't think the same can be said in liver ablation. We did a survey of methods. There's huge heterogeneity. So the key messages are: have regular surveillance imaging, attend your scans. Surveillance is there to guide treatment. Ablation can be an option for oligometastatic disease. Early treatment is more likely to work and less likely to affect your quality of life than late treatment. Don't be afraid to ask your oncologist about ablation options, because it could prevent the need for more invasive treatment later on. And more evidence is needed, particularly versus surgery and best medical therapy and over and under treatment. Just to say, this is what was in the charts when surgery became recognised. That's Bach. Ablation started with Oasis, so we are a new technology. This is just the beginning for us. We've got a lot of work to do. We're going to catch up, but we'll get there with some funding. I think that is our team. Yeah, thank you.
Pardon me if I missed this, but do you do photodynamic therapy?
Photodynamic therapy? No, is the answer to that. Actually, Robin, yeah.
Yeah, so Nicos and I over the years have had conversations about this, but there is a doctor at Guy's Hospital in London that does it, and we do refer patients to that doctor. But Nicos and I and the surgeons have had conversations about this over the years, and it can be particularly useful for people with cancer affecting the skin.
I know a woman in the U.S. who she had LMS in her lung, and we recently had a presentation where it was gotten rid of. I don't know how, but for the photodynamic therapy, and she's then been NED for 3 years.
Yeah, well, all of these local treatments are so useful, and Nicos and Ed and I are on the phone all the time, basically trying to sort of weigh up the the pros and cons of treating, and it can be really, really difficult. Yeah. I mean, desmoid tumour in particular, because that can shrink on its own. It's it's difficult to make this sort of judgment call about the way to cryo, but and Andrea can talk a little bit more about that. But it's
really
very
hard
difficult, because we usually use surveillance as part of the treatment for that tumour. So when do you make that call? And all interventions have potential.
Absolutely.
So it's challenging, but even more reason for us to work very closely together and discuss all of these cases together, basically.
Great presentation, thanks for that. Just one question, you said how big it has to be for ablation. In the lungs, how small can it be, and what's the smallest you've done here?
Gosh, honestly, the smallest we've done here is you can't see it. Sometimes, there are situations where patients will continue to have chemotherapy, and it will shrink it. I think you.
Yeah, and in a way, it comes back to surveillance, because sometimes when we discuss a really small lung area, Nicos and Ed will say, well, maybe we just wait a little bit and just see what happens, rather than just ablating a big area of lung when something's really, really tiny. So maybe in those situations we'd probably wait a little bit and just see how things evolve, and make sure that nothing appears elsewhere as well. So
yes, I think that I think in colorectal we're probably a bit more what's the word? Have a greater proclivity to treat, and sometimes their chemo means that the lesions will respond completely, but it can be just millimetre scale. Very often, having a completely absent lesion is rare, but we have done it.
So I'm wondering how you decide between surgery or ablation.
Well, that's never my decision.
It's a combined decision, though,
Yes.
Ed, isn't it? And
Yeah.
sometimes it's useful to actually get more tumour analysed, and in that case, surgery is obviously a very good technique. But sometimes after surgery, particularly for lung metastases, there can be a lot of pain and discomfort.
Absolutely.
And ablation is a much more non-invasive technique. So it sort of varies, and again, the whole point of discussing all of these complex situations in our meeting, weighing up the pros and cons. But I sometimes phone Nicos and Ed almost every day about things and say, what do you think of this? What do you...
Yes. I mean, some of the benefits of ablation, which I didn't cover, is that you can, with the liver, for example, if you cut out the right lobe, you've only got the left remaining. So to think that is, I think it would be naive to think that it was not at risk of further metastasis. So it can be repeated, and
And if there's just one area growing or causing problems, ablation can be really, really useful, and
yes.
Probably the best technique. Because again, I suppose in a totally different to colorectal cancer, a lot of our patients are on surveillance because the pace of the disease is really, really slow, and that's when we get in touch with Nicos and Ed if there is one area increasing or causing problems.
Yeah.
Thank you. I've got a question, actually. So in the UK, often if you tend to have multi-site occurrences, they generally suggest you to do chemotherapy. Is that purely because of funding in terms of the NHS? Because in the States, they tend to do a bit more of a whack-a-mole approach where they'll go for a different ablation in different areas.
Yeah, I think that's a fantastic question. And again, I suppose there's no right or wrong answer, but it's very much trying to gauge the sort of tempo of the disease and of the cancer itself. And patients would be referred to me in the US that had undergone surgery for metastatic disease that had been quote unquote a success, but there's a lot of there were more metastases on the sort of post-operative scan, and you just think, well, yeah, technically the procedure was a success, but in the overall management of the cancer, that was not a good thing to do. And again, it comes back to almost a treatment philosophy in terms of, selecting the best treatment for that individual patient. And I'd say if there are multiple metastases, it may be good to start with systemic therapy and assess the response. If there is a response, then consolidate that with local treatments such as surgery or ablation or radiation. Because if you start with a local therapy, there may be a chance that more metastases will develop, and it doesn't really make sense to treat the cancer in that way in terms of the global treatment for the patient. And I suppose the question isn't, can we do an operation? We can always do an operation, but it's, will the operation help the patient in this particular situation?
That's true. The clock study, though, which is actually the only phase 2 randomised trial that we have on ablation, and that's in colorectal cancer, so we're dealing with a different tumour type, but that did show that upfront ablation was additive to best systemic therapy. Whether that translates to sarcoma is probably it's a different entity.
Yeah, a completely different entity. And you know, one of the arguments sometimes about surgery for metastatic disease in sarcomas, it's always, well, if that person had carried on with surveillance for a period of time, their outcome is very likely to be the same. It's not the intervention, it's the biology of the underlying disease rather than the intervention that has the impact. Because you can remove the tumour, but it's the micrometastatic disease that unfortunately will actually kill the patient. So it's more the biology than the treatment itself.
If only we could run a randomised trial like CLOC in sarcoma, but it's much more difficult. And
there are so many moving parts in terms of the indolent nature of some sarcomas.
We have another question over here.
It looks like, first of all, a very, very good presentation. Thank you. It looks like the methods you described in ablation mostly involve physics, like deploying heat or freezing or radiation or whatever. Is there a hybrid methodology where you inject either chemical substances or biological substances and having a localized chemotherapy?
Yes, there is. Some of the early stuff. So there was the HEAT study, which was on liposomal doxorubicin in HCC, which was actually another of my collaborators, Prof. Goldberg, did that. Hasn't really taken off. There are other injectables that you could augment with RFA, but of course, with ablation, the tissue stays in. Whether that primes the immune system for systemic and so forth, these are all questions that need to be answered. Robin, you have another.
We have treated some patients with chemoembolization in terms of liver metastases. So Nicos has some great slides of over the course of 1.5 to 2 years of a tumour just shrinking with time. But as you say, it's not widely used, and it's very specific. There are only specific tumours that can be treated in that way.
Yeah, I mean, I know what Rito Barley would say, who is a real pioneer in stereotactic ablation. He'll treat up to 16 centimetres with 60 needles. He'll just say, do your ablation properly and don't worry.
Okay, thank you very much. So I'm just going to ask the last question, which is pot of money, what would you do with it?
In sarcoma, I'd see if I can sort those moving parts.
I'll take you up on that.
Yeah.
Thanks very much.